Orchidia Pharmaceutical Industries proudly announces the IOPROs can now be stored on the shelf at temperature not exceeding 30 Celsius for the proposed shelf life 2 years. IOPROs is now stable with no significant physical or chemical changes at 30 Celsius for the proposed shelf life 2 years. IOPROs shows the best tolerability profile across multiple dose prostaglandins analogs. Another product for your glaucoma patients is Travanorm. Travanorm helps more patients achieve desired IOP reductions. Thank you for your time.
We would like to welcome you all to the 10th episode of Glaucomatology 2020. And the episode this evening is on the two most practiced subspecialties in ophthalmology probably in the world today, which are cataract surgery and refractive surgery. So today we are exploring the relation of glaucoma with these two subspecialties. We all perform cataract surgery and we all perform refractive surgery, and not surprisingly that both of these can be associated with glaucoma. And this evening we have some of the best stars in both fields, or actually in the three fields. We have the honor and the pleasure to have Professor Ahmed Al-Masri, the outgoing chairman of the Department of Ophthalmology in Alexandria University, one of the most active figures in cataract surgery. We follow him in his international endeavors everywhere, whether the American or European societies of cataract and refractive surgery activities. He is organizing courses, he is giving talks, he is joining symposia. So he has a vast experience in cataract surgery and subsequently its relation to the glaucoma, and he has his own thoughts and ideas which we are looking forward to hear. We have also Professor Dr. Ayman Shayati, former president of the Egyptian Society for the Glaucomas and the chairman of the Department of Ophthalmology in Cairo University. Professor Ayman has always been interested in the cornea and the glaucoma, and he was one of the pioneers who started the work of refractive surgery on a very scientific, evidence-based basis since the beginning of refractive surgery in our area. And last but not the least, we have our coordinator, the glaucomatology moderator, the wonderful Professor Nader Bayoumi, who is going to show us his experience as a glaucomatologist, his thoughts about the glaucoma and the IOP changes and the IOP happenings following cataract surgery. We have these three stars, and we would like to invite our dear friend Professor Ahmed Al-Masri to give his talk now. Faddal, Dr. Ahmed.
Shukran. First of all, I would like to thank the Glaucomatology Yes, for inviting me to share with you the cataract and comorbidity. Especially, I would like to thank Dr. Ahmed Khalil, my dear friend and respectful professor that I do respect him as I always meet him, and how he is really an example of the real scientist that we need today in Egypt. My dear professor and colleague also, Ayman Shati, welcome you. And Dr. Nadir, of course, my dear brother and son. Really, I would like to thank all for allowing me to share with you the cataract and comorbid glaucoma conditions. As you said, Dr. Ahmed, really cataract and glaucoma are usually joined together, and we have a lot of cataract and comorbidities, the cornea, the refractive surgery, the glaucoma, uveitis, too many comorbid conditions with the cataract. Today, we're going to stress on the glaucoma conditions that we may face with the cataract and how to deal with. So let's take some basics. There are some debatable facts. When should we do cataract and glaucoma combined together? Simply, as we teach the undergraduates that patients who are compliant with controlled glaucoma on one drug, we just do the cataract surgery for them, or the phacoemulsification and intraocular lens implantation, as this usually in most of the cases, whether to relieve the condition, or we tell the patient that you may need still to go on with your drug after the surgery. One drug compliant, no problem to be to continue. But in cases of uncontrollable glaucoma with non-compliant patients, or on more than one drug, 2 drugs, for example, and with open angle, here we do combined cataract and trabeculectomy. In case of shallow angle glaucoma, phacoemulsification is more than enough to relieve the condition. So let's see some cases on how to deal with practically. First, the process of combined phacotrabeculectomy or phaco and combined cataract and combined glaucoma. I'm sorry that the video is a little bit old, but this is the routine steps that I'm doing, taking a fornix-based L-shaped conjunctival flap after injection of subconjunctival mitomycin and xylocaine. Mitomycin is 0.02%. And just clearing the sclera, taking the trab, as you, of course, all of you doing it better than me, whether triangular or rectangular flaps, half thickness. This is something very basic for the surgeons who are not very acquainted, or they are not doing the glaucoma and cataract many times, but you have the right to do both of them, whether separate incisions or from one incision. Many papers have been published saying that there is no difference between the results of having the cataract and glaucoma from the same incision or 2 separate incisions, but preferably the results were found to be of more value for the trabeculectomy to be from a separate incision after taking half of the thickness of the sclera, and the white meets the blue where Schwalb's is waiting for you. We are taking the trab and just demarcation here, and don't open it. And this is the difference between the regular trab and the trab with the phacoemulsification. Just demarcation of the trabeculectomy, and then go for your phacoemulsification with separate incisions, 1.2 millimeter side pores, as we usually start with, and then the keratome, 2.2 millimeter keratome from a separate incision, giving enough viscoelastic over the cornea. It helps visualization and inside the anterior chamber. Starting your capsular rexes, whether with the regular insulin needle that's bent like a Satu, or with the forceps, or whatever the way you want. The regular rexes should be continuous, curvilinear, circular, of 5.5 millimeter size to allow the insertion of your intraocular lens in the bag at the end. Then the step of hydrodissection, where we separate the nucleus and the epinucleus from the capsule, and then trying to rotate the nucleus, and this rotation may succeed or not. But the step of viscodissection for me is an essential step since more than 7 or 8 years that I'm doing viscodissection regularly after the hydrodissection. It helps separation of the nucleus from the epinucleus, and really it makes the rotation of the nucleus so easy. Then the phacoemulsification in a regular way, removal of the epinucleus first, one with the high ultrasound, depending on the hardness of the nucleus, preferable of 60% torsional ultrasound, using any machine that you are used to, adjust the minimum ultrasonic power, and then divide the nucleus into 2 halves with the preferable technique for every surgeon, whether the stop and shop as you see here, or divide and conquer, or whatever that you are mastering. And it's a very important point to be very careful, because having a rent in the posterior capsule in combined cases is really problem, because it makes all of the time the results of the trabeculectomy not as we wish, because of the increased intraocular pressure that happens with the vitreous when it occurs when it comes in the anterior chamber. This is a transverse shopping. All of the time, protect the phaco-tip with your second hand, which is the spatula, finishing the second the stage of phacoemulsification. Injecting viscoelastic before getting out of the phaco-tip is a mandatory process to keep the pressure of the eye pressurized, and decreases the incidence of posterior vitreous detachment after the surgery. Then the stage of the irrigation aspiration, whether to do it with separate irrigation aspiration cannulae, or with the regular Simcoe cannula, or with through the incision, depending again on your preference, and then insertion of the intraocular lens inside the bag. Here it should be put under hilum, not as we do in the regular cataract surgery under saline. Then go back to your trabeculectomy after injection of acetylcholine or pilocarpine intracameral, and then finish the trabeculum, taking the quadrant. Be sure that it's full thickness, and of course the assistance helps you to hold the flap and getting the trabeculum out, and then having your iridectomy and close your incisions or your sclera. After taking the iridectomy, and again, it should be full thickness, and a very small trick to know whether you prefer iridectomy is full thickness or not. Just having the red reflex be and magnify, and be sure that you see the ciliary processes and the red reflex behind. This assures that the peripheral iridectomy is full thickness. Then closing your wound with your preferable way to control the pressure. I prefer to take 3 sutures in the triangle, not so tight, and preferable to be an inverted sutures to close the scleral flap. And the most important step, as you all know, is the good closure of the conjunctiva to prevent the leakage or the shallow anterior chamber after the surgery. Again, we stress at the end of the surgery, the closure of the conjunctiva is mandatory, and especially when you put mitomycin, preferable to have the matrix suture between the conjunctiva and the cornea. Yes, it changes the vision a little bit, making the astigmatism a little bit high, but it secures the closure of the conjunctiva at the end of the surgery. You have to tell the patient that the vision will be a little bit different than the usual cataract surgery, because we are taking sutures in these cases, and these sutures are mandatory in the trabeculectomy. There is no trabeculectomy without sutures. And after this tight closure, we have to test the flow of the aqueous through your trabeculum or your trabeculectomy. Again, these are the 2 sutures. That's why the smaller the conjunctival opening, the more controllable will be the flow. And again, don't forget to take the matrix suture. And many times we put the patient under air, and the post-operative, as usual, antibiotic, steroids, and cycloplegic, whether to put an air bubble or not. This is the matrix suture, which is mandatory as long as you put the mitomycin, which is a routine step now for all our surgeries. So this is just to simplify, to have rapid review about the combined cataract and trabeculectomy and how to do it. There is no need to take sutures in the phacoemulsification wound. It is a self-sealed incision, whether through the 2.2 millimeter incision or even 2.6 or 2.8. But sometimes in cases of shallow angle, like in this case, the patient was presented with shallow angle glaucoma, angle closure glaucoma. He's not diabetic, and as you see here, the pupil is not so dilated. And of course, dilatation of the pupil is another problem for the shallow angle cases. It should be dilated immediately before surgery or even in the OR. The capsular rhexis is difficult because the anterior chamber is very shallow. In this case, it was less than 2 millimeter. And as you're going to see that the power of the IOL was plus 40. And this is the main cause of this shallowness of the angle. And if the intraocular pressure is high before the surgery, in spite of giving the mannitol preoperatively, you can do pars plana vitrectomy. And please, vitrectomy, not vitreous tap. Vitreous tap is not the proper way to take from to do the vitrectomy, but you have to do through 23 gauge pars plana vitrectomy with the trocars. Do the proper vitrectomy. It's just colorization of the mid-vitreous if the pressure is high. But if the pressure is not high and it's controllable, you can proceed with just your regular way. But be careful with the capsular rhexis because it is the most difficult step, preferable under general anesthesia if possible. And then once you have the capsular rhexis, by every step you will find it's easier than the previous step because while you are removing the lens, which is a very thick lens, you will find there is an ample space for the intraocular lens to be put. Just concentrate on the power of the lens that we are going to put, as it is shown under the microscope before insertion. It is a plus 40 intraocular lens, and that's why the patient was so simply satisfied. This is the plus 40 diopter powers, which is available in some companies, and then injecting your intraocular lens. Of course, here you have to enlarge the incision a little bit because it is a very thick lens, and the intraocular lens, and then put it in place, and this relieves the condition. Sometimes patients after trabeculectomy, they have uveitis. This patient did it just 3 days before, the day before yesterday, and you are trying to dilate, and you will find the membrane. This patient did glaucoma before, as you see the trabeculum up and the bleb. Here you find the membrane. It's very easy to be removed. Take care. This is the main cause of the non-dilatation of the pupil. Of course, we put all kinds of medullaritis before, but this membrane appears as cells in front of the lens. This is a true pupillary membrane, which is formed and makes the pupil hardly to be dilated. Wait, and even this part should be removed. As I'm always saying, the anterior segment surgeon should have his own end gripping forceps or the capsular rhexis forceps microincision 1, which helps removal of this membrane. Gentle, assisted by the second hand, gentle removal of this membrane from the iris will not induce bleeding, which you are afraid from. You may find just micro bleeders, but controllable with the pressure. And once this membrane had been removed, it turned to a simple, straightforward cataract patient. You can here reassess whether to put iris hooks to dilate the pupil, or there is no need for the hooks, and you just do your capsular rhexis with the proper size with this pupil, and with your second hand in which the spatula is present. And I do prefer all of the time to have in the second hand the spatula, which helps dilating the pupil at the areas where you cannot see. Okay, sometimes also from the conditions that we may face, that we may have a good trabeculectomy, but it took a long time for anterior chamber to be formed. As you see here, while we are doing the cataract surgery, and this patient did the trabeculectomy, and still the sutures, there is the matrix sutures is still present, and there is a leak from this trabeculectomy. So please don't leave this patient with this leak, because he will suffer a lot after removal of the lens, because you'll have a shallow anterior chamber with all its sequences of choroidal detachment or whatever. And so after finishing your phacoemulsification, putting enough viscoelastic, this patient was a little bit mature cataract, or you cannot see even the red reflex. So trypan blue is the best stain. As you all know, there are different stains for cataract like the trypan blue, gentian violet, and methylene blue. All of them approved. They are toxic to the endothelium, except the trypan blue, which is not toxic to the endothelium. It doesn't affect the endothelium. Again, the hydrodissection, the viscodissection, and the regular phacoemulsification. But at the end of the surgery, when you finish your phaco and putting your IOL, you cannot leave this trabeculectomy leaking like this. As you see, the trypan blue was leaky through the trabeculum all of the time and the aqueous. So this is a not proper trabeculectomy. It should be secured. So after finishing your phacoemulsification, as if we are doing a combined trab, you have to do a conjunctival to open the conjunctiva and to properly close the trabeculum if there is any leak. And yes, after finishing the surgery and putting your intraocular lens inside the bag as usual, and after finishing the surgery, you are doing the conjunctival flap and closure of the scleral flap also, and then closure of the conjunctiva again, very securely, as if you are doing trabeculectomy and phacoemulsification. So after finishing the surgery, here is the conjunctival flap, as usual, fornix-based, limbal-based, fornix-based flap, and then undermining of the conjunctiva around the scleral trabeculum, and cauterization. And to be sure what happened in the trabeculectomy and the scleral flap, yes, there is some leak, so you have to secure again the scleral flap and to close it thoroughly, and then close your conjunctiva again tightly, as you are adapted to in any trabeculectomy. So here we are taking again another inverted suture in the old trabeculectomy, which is more than 5 to 6 months before the cataract surgery, and then closure of the conjunctiva with tight closure and good closure, and good undermining to close the areas that were not covered before from the trabeculectomy and the scleral flap. Again, at the end also, taking the conjunctiva properly and close it from all sides, because it was a little bit larger than the usual. After tight closure, again, don't forget to take the matrix suture in order. This prevents the recession of the conjunctiva flap back and exposure of the scleral flap, which may induce again more leaky if you didn't do this. Again, in pseudoexfoliation, which is a common condition in Egypt, of course, you know that the patient, this is a typical pseudoexfoliation case where you find the zonules are very weak, so be careful. It should be a very slow phaco. These are the dandruff or the areas which are covering pseudoexfoliation membrane, which is covering the anterior lens capsule, and this is really may change your capsulorhexis direction. So it should be very careful and very slow in doing your capsulorhexis. Sometimes that the zonules may be anteriorly inserted, so the extension of the capsulorhexis may happen. As long as the patient has pseudoexfoliation, you have to have very slow phaco all of the time in order not to endanger the zonules, and preferable not to rotate or the gentle rotation of the nucleus. And the viscodissection helps the rotation thoroughly and facilitates the rotation of the nucleus. As we said before, you all of the time should do very slow phaco, because you should put in mind all of the time that the zonules are very weak. So you may face iatrogenic zonular dialysis that will change your plans and enforce you to put ring, whether capsular tension ring or Ahmed segment ring. So when you are doing phaco in pseudoexfoliation, all of the time be prepared that you may need one of the capsular tension rings, and all of the time give it enough time, more than your regular phacoemulsification, to finish the surgery safely, having plan B behind with the rings. This was a straightforward case with putting the IOL in the bag, and it passed safely without any dehiscence of the zonules. But in a case like this, where you really face a very weak zonules, it is the pupil was not dilatable, so I decided from the start to put iris hooks to dilate the pupil. And as you see here, instead of iris hooks will take time, but definitely will save a lot of time to have a successful surgery. it's an interesting case, really. So I know it's a little bit, may take a long time, 5 minutes, but I think we may value from the from this video to take in the decision making, especially. And after taking your iris hooks and dilate the pupil thoroughly, so now you can do your capsulorhexis safely. And up till now, there is no dislocation or any problem in the lens. But see, once you are inside with the insulin needle, you find that the whole lens is floating. Nearly most of the zonules are very weak. So preferable here to use your microincisional forceps, assist holding the lens from the good part that you did from the small rhexis to fix the capsulorhexis, and to continue with having the bimanual rhexis, which is a very important tool that helps in completing the rhexis, which is really a hard time to have rhexis in a case like this, because you cannot even think in converting to extra cap or to remove the lens all in all. So I decided to have the hooks in the capsular bag. So this is a decision that is just in this case, because it wasn't available, the capsular hooks here, but the iris hooks work good for holding the anterior capsule gently. And from one side, it was still not stable. So I put another iris hook in the 108 degrees against the first one. And here the lens became stable. Now we have a stable lens. The capsule is stable, and you proceed your phacoemulsification, and then take your decision lately whether you are going to put capsular tension ring or whatever. But don't think in anything except that we are doing now. Now I'm looking to the anatomy of the lens, doing my phacoemulsification, very short tunnel. I know that the lens is markedly moving and it may drop at any time, in spite of holding the lens with these capsule hooks or iris hooks. Very gentle division till we finish. And as you see, while you are taking your epinucleus, you find that the bag is coming at the areas where here, as you see, here is the bag is coming, so the zonules are very weak. So at the end of the day, yes, it took a very long time, but we finished phacoemulsification with an intact bag and capsule, anterior capsule and posterior capsule. Then what you are going to do, are you going to put an IOL in this highly moving capsule? Is it going to withstand? We saw in many cases, after many years of implantation of IOL in patients with pseudoexfoliation, that they may drop the bag, the IOL capsule complex. So removal of the iris hook from the bag, and of course from the iris. I don't need this very large iris, and be gentle while you remove it in order not to get your bag with the removal, and then reassess the bag. So I'm returning the bag and the capsule. Yes, it is very, very mobile. So I decided safely for this patient, I removed the capsule. Here, the anterior vitreous face is still intact. Here is the capsule that we are looking for. The whole capsule, which is intact, and the whole bag with the anterior capsule and the edges. There are no zonules at all, as if we put the alpha-chymotrypsin in the old days of the intracap. Then we remove the iris hooks. And what's the decision here? Very simply, you have a regular pupil. You have people that could be easily closed with the pilocarpine, and the safest is to put an anterior chamber, very size or artisan IOL, whatever the name of the company. I have no financial interest. And again, injecting pilocarpine with mild stimulation of the iris at the edges. You have regular small pupil that you can insert your anterior chamber or the phakic IOL over it through a 6mm incision. Yes, you'll have some sutures, but again, this is the most safe for this patient after this long and tedious surgery, putting them anterior chamber phakic IOL in place and with inclination. I prefer putting it in the anterior chamber than in the posterior chamber. I'm not a posterior segment surgeon. I'm afraid from this IOLs to fall down. We see many cases of loss of inclination, and you may re-enter the patient for re-inclination, sometimes, especially in children. So I prefer putting it in the anterior chamber than the posterior chamber. And don't forget to take the peripheral iridectomy. So here the decision was removal of the whole bag, keeping the anterior vitreous intact. It is a straightforward surgery with a very sidened anterior chamber. The patient benefits from having the IOL in place and benefits from having no vitreous loss, and you kept your normal anatomy and configuration of the eye as it is. In conclusion, we can say that glaucoma surgeon should have skills for phacoemulsification. There is no doubt of that. Decision making is crucial to assess the success of cataract surgery in patients with glaucoma. Patients counseling is mandatory. You have to tell the patient you have many problems, not only just one problem. You have cataract and glaucoma, especially patients with compromised optic nerve. My routine for all my cataract patients, whether glaucomatous or not, I'm doing an ocular complete tomography, OCT for them, for the optic nerve and the macula. Many times to discover macular holes, whether lamellar or free thickness macular holes, before the surgery. And many times we find compromised optic nerves, especially in high myopes. And what you are telling the patient before surgery is a fact, but if you're going to tell him after the surgery, it's a doctor's complication. So the best thing is to protect yourself, having all the investigations done for him, as long as you have it and it's accessible for you, and to discuss with him the problem of his optic nerve and what's the prognosis of this optic nerve is very important. And again, the compliance of the patient, of the glaucoma patients after cataract surgery, is an important issue, because many of these patients may need again to go back to their eye drops to control their pressure. And I'm sorry that I took a long time. And thank you so much for the invitation. And if anyone needs the presentation, of course, I can send him by mail or through the recording of the webinar. Thank you so much.
Unmute, Dr.
شكرا دكتور أحمد.
Thank you very much, dear Dr. Ahmed, for this very rich presentation, full of actually cases and full of possibilities and management plans. Let me ask you a few questions on the exfoliation, actually, because this might be one of the most common entities associating glaucoma and cataract.
Yes.
I ask you about the capsular rhexis. Does it have any special feel in the exfoliation patients?
Yes.
Is it more difficult? Is it in itself? And then the second question actually is interesting to know. How often in our patients in Egypt and in the Middle East do you find the zonular dehiscence in exfoliation patients? Zonular dehiscence big enough to count for special maneuvers like you did in your very interesting last case? How often do you find in your exfoliation patients? How was the percentage in your case?
The answer of the second question first, honestly, it's not so often. You know that the pseudo-exfoliation is, we can see it very often. The pseudo-exfoliation
Yes.
is, but having weak capsules in the weak zonules in the pseudo-exfoliation is not so common. It's not more than 5 to 10% actually.
Okay.
So every 10 pseudo-exfoliation patient, I may find one, or every 20 may find one or two with weak zonules. The really case like the last one, it's not common to see. It's a really rare case and it's a very difficult case. And we cannot count on zonular dehiscence like this case, because in the pseudo-exfoliation, we find the capsular dehiscence may be just 1 o'clock or 2 o'clock. So this is a very important message also for the audience, in order not to be afraid from doing any case of pseudo-exfoliation that they may suffer facing a case like that we did the last one. But the usual cases are cases with no zonular dehiscence. But we have to be careful to the answer of the first question of the most important step is the capsular rhexis in patients with pseudo-exfoliation. The point with that in patients with pseudo-exfoliation is not only the matter of having weak zonules, but also that there is an anterior insertion of the zonules. This anterior insertion of the zonules may be very close to the 5.5 or 6 millimeter diameter. So we should be very careful in every step while we are doing our capsular rhexis to be very well oriented. Where are the zonules, whether they are nearly inserted near the anterior capsular area that we are doing the capsular rhexis or not. So preferable to be toward the 5 millimeter size, preferable than the 6 millimeter size. Of course, the optimum is 5.5, but preferable to be a smaller size. The second point, which is mandatory, is having the second hand. As you saw in all the videos, I'm not holding with the colibri or corneal forceps, the conjunctiva or the sclera, but all my maneuvers are with the spatula in the non-dominant hand through the side port. So this side port helps or assists in controlling the capsular rhexis size, controlling the capsular rhexis flap, and controlling the capsulorhexis if the lens is moving. So we can hold the capsulorhexis with the second instrument, which is the side spatula or the iris spatula, and we can make our rhexis completely, but needs cautious. Need very slow phaco, very slow. Don't rush at all. You don't have anything most important than this eye now. And take your time during the phacoemulsification, which is again should be slow phaco. As we say in many comorbid conditions, slow phaco is very valuable because it prevents the complications. You have to make the vacuum low, the ultrasound low, and you have to be as if you are a beginner and start every step very cautiously.
Thank you very much. Actually, this idea and technique of bimanual rhexis is actually interesting to hear and see. And some of your techniques naturally are actually very advanced. Like the one I'm going to ask you about, the use of, we have the capsular hooks and we have the iris hooks.
Yes.
And yes, we know that we do not come across capsular hooks very often in Egypt.
Yes.
Or probably in the Middle East, they are there, you can get, but not as easy as the. So how safe do you feel in putting the iris hooks to support the bag? And also, do you put all the hooks in the bag or only a couple of them to fix the bag during your phacoemulsification?
Again, to be honest, this is not a message to put all the iris hooks in the capsule, as you said, because we have our capsular hooks, but as long as you have regular, continuous, curvilinear, circular capsulorhexis, the iris hooks usually withstand holding the capsule. But you have to have regular rhexis. And it's more than enough to put the least amount of iris hooks to fix the capsule. So just putting 2 are more than enough because they hold the capsule from 180 degrees apart, and this can fix your capsule temporarily. But it's not a must to put the capsular hooks, and again, it works with the capsule.
Okay, and then another question, actually, it is a dual question. We have a question from the audience, from the floor, about the use of lenses in the anterior chamber in glaucoma cases. And on the other side, or on the other face of the coin, I'd like to ask you also, do you sometimes try the difficult techniques of posterior fixation, of maybe implanting in the bag, keeping the bag and fixing the bag to the sulcus or whatever of these techniques?
Sure. As I'm saying, you have to have a plan before doing your surgery. You have to plan whether you're going to put an IOL with the Yamani technique, for example, or for the scleral fixation techniques, which are a lot of them, hundreds of techniques are available. Again, or it's preferable to protect this patient to put the simple Versailles or artisan lens. My experience is I didn't face any problem with patients with Versailles or artisan in patients with glaucoma, as long as you took a good iridectomy and you monitor the intraocular pressure. Of course, you may answer this question better than me because you have more experience in these situations, but good peripheral iridectomy, monitoring the intraocular pressure after putting Versailles in a glaucoma patient, I don't think that it will affect the intraocular pressure, and I need to hear from you also what's your opinion in this, whether I'm right or wrong. And the second thing, yes, we can do the other procedures of, as I said, scleral fixations, which is a time-consuming and need, again, experience, depending on the situation. You already took in the phacoemulsification about 50 minutes, and putting the Yamani technique or other thing will take another 20 minutes. And I do respect the shorter time for better results for the eye. As long as you take less time, proper management, this will be the best for the patient. So yes, I'm doing the secondary IOL fixation techniques, but I prefer that patient putting the Versailles or the artisan in the anterior chamber.
Yes. Actually, I actually agree with you, and maybe if Professor Ayman or Professor Nader have some opinion you'd like to hear about, I mean, if you put the anterior chamber lens very correctly in place, regular, and it's a very just place, it might not be actually a big problem in our glaucoma cases. And then we have a question from the audience about cataract surgery in Postner-Schlossman syndrome. Any special precaution you would have in such cases? They are rare cases, but we every now and then meet them.
I don't think I have any special precautions in these cases. I treat them like any other case. Like if there's some uveitis, as you said, we remove the membrane and we deal with them as the usual cases. I don't have something specific for the post-Straussman syndrome.
Okay. And this is a very classic question about doing them together or doing them separately. Yes. Apparently, all the cases you have showed that you do them together. You didn't mention other except that case which you did cataract following a leaking blood. So do you sometimes do sequential surgery?
Yes, of course. Yes, this depends on the patient and its compliance, whether he's from Egypt or from abroad, whether he's compliant on drugs or not, and whether he can afford for doing 2 sequential surgeries, whether to do the cataract first or the glaucoma first. This, as I said, first basics, but they are debatable facts, as I showed in my first slide. So yes, we can do sometimes sequential surgery. Many of the cases, as you saw, that they did trabeculectomy and they are followed by cataract after that. And for the shallow angle, we did the cataract first and they didn't need trab after that. And the first case was combined, depending on the...
Yes. Do you sometimes make clear lens extraction and angle closure glaucoma cases, Dr. Ahmed?
Yes, but I'm not so pushed to do this, of course, to do clear lens extraction, especially for young patients. So I don't like the clear lens extraction, honestly, for the shallow angle glaucoma. I don't know, again, what's your opinion in case like this, Ahmed?
Yes, الحقيقة إنه برضو we usually you find them in elderly patients more who come to you with some chronic angle closure glaucoma, and the cataract is too early. The cataract is not a cataract which you would operate normally, but then you find this chronic angle closure and an elderly patient. As you said, I agree with you, not in younger patients, but with an elderly patient, we might go, yes, and we do the semi-clear lens extraction or very early cataract extraction in these eyes. Yes, this is Dr. Ayman, Dr. Nader Bey. Do you have any comments to?
I agree with you. I agree with you for the extraction in angle closure glaucoma that we would do the cataract earlier that we used to do.
Okay. Yes, thank you. So I think we agree that I mean, now in angle closure glaucoma, chronic angle closure glaucoma, it might be a good step to do early. And like Dr. Ahmed BL just said, it might save us the glaucoma operation itself.
Yes.
And it was once said, it is an old saying, I will tell you who said it, but it was said once that cataract surgery in itself is the most commonly performed glaucoma surgery in the world. We might agree or disagree, but I mean, it has definitely a role in the lowering the IOP.
Yes,
sorry?
Debatable facts.
Debatable fact, exactly, yes. Okay, yes. So thank you very much, dear Sir, Professor Dr. Ahmed Al-Masri, former president and chairman of the Department of Alexandria University. It's a really pleasure and honor to have you. Thank you very much. And please stay with us tuned with the following speakers. Thank you again.
Thank you so much, Mr. Ahmed. ألف شكر. شكرا جزيلا لك.
عفوا. ربنا يبارك في حضرتك.
ربنا يبارك لك.
Now we have the intermission with the Orchidia announcement or Orchidia advertisement. And before that, actually, we have some sad news to say that few hours ago, it come to our knowledge that Dr. Bashir Al-Tabbakh, the chairman of the Department of Ophthalmology in the Sou General Hospital, has passed away with COVID-19. Inna lillahi wa inna ilayhi raji'un. We pray for his soul. We pray for his family, and we remember him in this day when we are together in this meeting. تغمده الله بواسع رحمته وألهم أهله السلوان والصبر يا رب. ويعني وربنا يجازيه كل خير بأي حاجة حلوة عملها. And now we move forward. Do we have the Orchidia ad?
Hello, doctor. Greetings from Orchidea Pharmaceutical Company. I hope you, your family, and all your beloved ones are safe and in good health. Today, I'm going to talk about our latest introductions for your glaucoma patients. Taflopro single-dose unit offers better IOP control to reach a target IOP. Taflopro single-dose unit reduces IOP significantly in patients with prior prostaglandin monotherapy. Taflopro single-dose unit ensures no severe hyperemia experience with other prostaglandins. Another product for your glaucoma patients is Taflopro plus single-dose unit. Taflopro plus single-dose unit provides numerous benefits when compared to non-fixed combinations. Taflopro plus single-dose unit offers extra IOP control up to 22.3% when switching from prostaglandins analogs. Taflopro plus single-dose units offer a better local comfort. Thank you for your time.
And now we are back to our distinguished speakers. And if cataract surgery is one of the most performed surgeries in the field of ophthalmology along history, but probably the most commonly practiced and operated surgery in current and recent years is actually not cataract surgery, but LASIK surgery all over the world. So does laser vision correction, does corneal refractive surgery have any role or any problem with the glaucoma and with the rise of intraocular pressure? For the casual listener or for the casual practitioner, maybe not. What's the relation between cornea and corneal refractive surgery and the glaucoma? So we would like to hear the experience of Professor Ayman Al-Shayati, professor and the head of the department in ophthalmology in Cairo University. Dr. Ayman,
Ex-chair.
I'll go.
Thank you. Thank you for the invitation. And thank you for Dr. Ahmed Al-Masri for his very interesting talk. And it's very difficult to speak after Dr. Ahmed Al-Masri, as a matter of fact. My talk is about intraocular pressure generally in corneal refractive surgery. As a matter of fact, intraocular pressure should be considered in all stages of corneal refractive surgery: before surgery, during surgery, and after surgery. Before surgery, we have to be sure that the patient is not high risk for elevation of intraocular pressure or will not have any harmful effect from the high intraocular pressure that we induce during application of the suction ring. And we have to make sure that the patient is not at risk of steroid-induced intraocular pressure when we intend to use intraocular pressure for a long time after corneal refractive surgery. The corneal thickness is usually a measure that we take routinely before corneal refractive surgery, and it's important in assessment of the intraocular pressure after corneal refractive surgery. As a matter of fact, a good history of any anti-glaucoma drugs that can be used, that was used before surgery, is important, as at one time brominidine was accused to be a cause of slippage of the flap of the LASIK more than usual. During surgery in LASIK, we induce elevation of the intraocular pressure up to 65 millimeters mercury. And this elevation of the pressure is important to be sure that, the ring is properly applied. And so we have to be sure that this intraocular pressure is high enough. And this can be done by what we call a Barraquer tonometer. Barraquer tonometer is a cone of polymethyl methacrylate with a ring like that of the application ring, and it is put on the surface of the cornea, and the meniscus of the fluid should be within the ring of the PMMA cone. If it is outside this ring, then the intraocular pressure is not high enough and it's not secure. A pneumotonometer can be used intraoperatively, and it is accurate and safe. But as a matter of fact, from the practical point of view, we depend on the dilatation of the pupil. When we apply the pressure, the pupil should dilate. And if it does not dilate, this means that the intraocular pressure is not high enough. You see here that the pupil is dilated. And you can test the intraocular pressure by your finger and you be sure that it is high enough. It is important to not leave the intraocular pressure high for a long time and try to make the procedure during the high intraocular pressure as short as possible to avoid the potential risk of any retinal vascular accidents. Post-operatively, we have 3 issues. The issue of steroid-induced intraocular pressure, and how to measure the intraocular pressure, and lastly, what's called PISK. Intraocular pressure after corneal refractive surgery, we know that usually what we measure in the clinic is underestimation of the actual intraocular pressure. And it has been estimated that it may be up to 7 millimeters mercury in radial keratotomy. In PRK, we used to add 0.5 to 3 millimeters mercury when measuring the intraocular pressure, and a series of equations and nomograms have been put to calculate the intraocular pressure after corneal refractive surgery in PRK. And in hyperopia, there may be underestimation of the intraocular pressure by about 0.5 millimeters mercury if the correction was less than 3 diopters, and by 1.5 millimeters mercury if the correction was more than 3 diopters. In the LASIK, a lot of nomograms have been put forwards. For example, adding 2.5 to 4.5 millimeters mercury to the actual reading of the Goldman applanation tonometer, or to add 0.3 to 0.5 millimeters mercury for every diopter of myopic correction, or to add 1 millimeters mercury for every 30 to 40 microns of ablation of the cornea, or just to add according to the amount of correction, 1 millimeters when the correction was 1 to 5 diopters, 3 millimeters when it is 6 to 10 diopters, and 5 millimeters if it is 11 to 15 diopters. We don't know actually what's the cause of the change of the intraocular pressure after corneal refractive surgery, but we are speaking about the change in the biomechanics of the cornea. What affects the biomechanics? It may be the corneal thickness, the corneal curvature, or the induced astigmatism and the high order aberrations. There may be the deficiency or the affection or the weakening we induced in the Bowman's layer. And there have been trials to compare between the central and peripheral intraocular pressure after corneal refractive surgery. Which apparatus should we use for intraocular pressure measurement after corneal refractive surgery? The regular apparatus, and it's available in all clinics, is the Goldman applanation tonometer, and we can use the compensation equations as I just said. The pneumotonometer is accurate, but the air puff is not accurate because the air puff depends on the smoothness of the convex surface of the cornea, and so it's not accurate at all after corneal refractive surgery. The tonopen is accurate, and it is more and more commonly available in the clinics, and it's a good tool. By the beginning of the 20th century, there have been a term of dynamic observing tonometry or dynamic contour tonometry, and we heard about some lenses as the Pascal, and then other apparatuses have been found in the market, which is the Ocular Response Analyzer, Aura, and Corvus, and I'm going to speak about these. The smart lens for diagnostic or observational tonometry, the concept was that is to observe the optic disc and to observe the angle in the same time of measuring the intraocular pressure and measuring the ocular pulse amplitude. So it is used as any contact lens on the slit lamp, and it is applied to the surface of the eye and connected to a basic station, and initiated by a push button. Just you press the lens on the cornea of the patient, and then this is connected to a PC with a software for analysis of the results, and you find the intraocular pressure with its fluctuation and the ocular pulse amplitude. And this is the theory that it makes applanation and by the same time monitors all the oscillation of the intraocular pressure and the ocular pulse amplitude. But it was cumbersome, and it's difficult to have a lens and a basic unit and to connect them to a computer. Then the same company put it into what it called Pascal lens. So it's a digital contact tonometer, and it can be mounted to the slit lamp as the Goldman applanation tonometer, and gives numeric output of intraocular pressure and ocular pulse amplitude dynamically at the same time. So this is like the Goldman applanation tonometer. Then we came to the era of ocular response analyzer, ORA. The concept is by just projecting an air jet to the surface of the cornea. So the air jet presses on the surface of the cornea, making the convex part of the cornea to be concave, passing into an applanation phase. And then when the air jet is stopped, then the cornea returns back to its normal convex position. And during this forward and backward movement, there is two positions of applanation. Applanation when the air jet is applied, and applanation when it returns from the concavity to the convexity contour. And the difference between these two applanations is called the corneal hysteresis, and it represents viscous damping in the cornea. And another index is the corneal refractive index, which measures the rigidity of the cornea. And by mathematical calculations, we can calculate the intraocular pressure CC, IOP CC. This is the corneal compensated intraocular pressure, which is claimed to be less affected by corneal properties, and the IOPG, which is the counterpart of the intraocular pressure when measured by the Goldman applanation tonometer for this cornea. Then we come into the market the Corvus. Corvus stands for Corneal Visualization Scheimpflug Technology. And it depends on the same principle of the aura, but it monitors the movement of the cornea by slow motion video of the corneal deformation after the air pulse. And it calculates the deformation amplitude, and then can calculate the intraocular pressure. So we have Scheimpflug images of applanation moments and highest concavity, and a lot of indices can be expected. And they use one of the most recent index is the tomographic biomechanical index, which uses artificial intelligence to analyze the corneal biomechanical index so that we can expect or predict the biomechanical changes of the cornea under examination. The last point I'll speak about is what's called PISK, pressure-induced stromal keratopathy. This is a common clinical scenario of a patient undergoing LASIK surgery, and post-operatively we find a haze in the interface. The most common interface haze after LASIK surgery is diffuse lamellar keratopathy. So the first diagnosis which comes into sight is diffuse lamellar keratopathy, and the treatment is by steroids. Then we start steroids aggressively, and if this patient is sensitive to steroids, a steroid-induced elevation of the intraocular pressure may occur. And if there is interface in the face, in the interface fluid, like here, you will find that by elevation of the intraocular pressure, more aqueous is pushed into this potential space, and this space becomes larger, and so the opacity will increase. The interface opacity will increase, and the assumption of that it is a diffuse lamellar keratopathy. On assumption of that, more steroids are pushed, and to measure the intraocular pressure to be sure that the patient is not steroid induced, we find that the intraocular pressure is lower than normal. Why? Because we applanate just the flap of the LASIK against the fluid in the interface. It is not against the stroma of the cornea. So we falsely measure the intraocular pressure as very low intraocular pressure, and so we can increase the steroid. We feel with a false safety that the intraocular pressure is not high, but this is not true. So it's very dangerous, and so you have to look at the interface and to be sure that there is no fluid in the interface. As a matter of fact, PISK has been described by many other names, like interface fluid associated with diffuse lamellar keratopathy, interface fluid after LASIK, steroid-induced glaucoma after LASIK associated with interface fluid. This is describing the pathogenesis of the condition. Then Bellin in 2002 described the condition as PISK, and still other titles and other description of the condition has been put forward as interface fluid pocket after LASIK. So the take-home message is that intraocular pressure should always be considered before, during, and after corneal refractive surgery. And intraocular pressure should be compensated when measured after LASIK surgery. And for the practical points is that either you add 0.4 millimeters mercury for each diopter of myopic correction. For example, if the intraocular pressure is 16 and you corrected 10 diopters, then you add 4, then the actual intraocular pressure is 20. The other choice is to calculate the difference between the preoperative intraocular pressure and the postoperative intraocular pressure and add this difference to any value measured postoperatively. So you measure the intraocular pressure directly before the surgery, before the corneal refractive surgery, and you measure the intraocular pressure after 1 or 2 days after the corneal refractive surgery, and you calculate the difference. For example, it was 16 before surgery, and it becomes 14, then the difference is 2. So in any further in the future visits, you add these 2 millimeters mercury to what you measure in your clinic by the Goldman applanation tonometer. If you don't have in your records operative intraocular pressure, then you can ask for an ocular response analyzer to get the corneal compensated intraocular pressure and the Goldman intraocular pressure of the ORA. And you take the difference, and this difference you use it to add to your measurements in your clinic by the Goldman applanation tonometer. So if the difference between them is 2, then you always add 2 to the intraocular pressure measured in your clinic by the Goldman applanation tonometer in any visit. The last thing is that you have to notice the interface between the flap and the stroma in any case of corneal haze, and confirm that there is no accumulation of fluid there. Don't depend on the intraocular pressure measurement if there is interface fluid. And thank you very much.
Thank you very much, dear Dr. Ayman, for this very interesting presentation about a surgery or an operation which has become the most commonly performed surgery in the world of ophthalmology. I'd like to ask you about the best way to measure. You explained to us several machines and several instruments which we use. Of course, the compensation is probably practically what we all do, the compensation, and your take-home message about the compensation of the IOP reading using the Goldman applanation tonometer. But then with the current systems you have described, do you have one in particular which you see most useful or most practical? And I would also ask you about, do you have any experience with the use of eye care post-refractive surgery?
I don't have any experience in the use of eye care post-refractive surgery, but as I mentioned, you can choose one of these 3 methods I mentioned in the take-home message. The most practical and the easiest one is calculating 0.4 millimeters mercury for each diopter of correction. But this you do it when you don't need to follow the intraocular pressure. But if the patient develops glaucoma later on, and you have in your record intraocular pressure, but you didn't measure it directly after surgery, then you have to assess the difference between the true intraocular pressure and the Goldman applanation intraocular pressure. And then you have to resort to one of the machines, either the ORA or the Corvus. We use the ORA, we just use it once. To calculate the difference between the corneal compensated intraocular pressure and the Goldman intraocular pressure of the machine, of the ORA. And then you take this difference and you add it to your Goldman applanation. You don't depend on the Goldman applanation intraocular pressure of the ORA. You depend on the Goldman of your clinic. But you take the difference from the ORA. And then you calculate, you depend on this measure all the time in the follow-up of the patient.
This is very interesting to know and to learn, actually. This is very interesting. And what about the Corvus? We have a question. Do you use the Corvus, or is it of good use?
The Corvus is much better in the biomechanics, but the Aura is satisfactory for just measuring the difference in the intraocular pressure.
Okay. And then I'd like to ask you about your personal experience of the use of post-operative steroids following LASIK. How often do you use in your patients?
Maximally 2 weeks.
Maximally 2 weeks.
2 weeks. But I do a lot of PRK, and I use the steroids for 6 weeks after PRK. But I use usually surface steroids like fluorometholone, not dexamethasone or prednisolone.
You don't use dexamethasone or prednisolone
in PRK. In PRK, I don't use. Yes, because I use them for 6 weeks, so that to decrease the incidence of elevation of the intraocular pressure. Fluorometholone has much less effect on intraocular pressure than dexamethasone and prednisolone.
Okay, and we have a question. Is there a difference between PRK and LASIK and the relation to glaucoma and rise of IOP?
During surgery, you compromise the disc more in the LASIK because you elevate the intraocular pressure 65 millimeters mercury. In the PRK, you don't do that.
Yes.
So if you can make a patient who is controlled on glaucoma treatment, on a single glaucoma treatment, and you have to do to him refractive surgery, if you can do PRK, it will be better. If PRK is not an option, for example, for his refraction, or he cannot tolerate the post-operative pain, then you can do FEM2, because the elevation of the intraocular pressure after application of the FEM2 cone is much less than that of the LASIK, of the manual keratoconus.
Although it is much longer.
It's longer, but it is but less intraocular pressure.
Okay, and then if you have a well-controlled glaucoma patient, would you safely go for PRK, maybe not LASIK or LASIK correction?
If he is in a single eye drop and he's well controlled and compliant patient, I would do for him refractive surgery. But if he is difficult for follow-up or difficult for control, I wouldn't do that.
Okay. And I'd like actually to make a comment on the very interesting thing you mentioned about when the cornea is elevated by fluid and the corneal edema, because the cornea is apparently thicker. And we classically know that a thick cornea produces a higher intraocular pressure. But here we have the other way around.
Yes. But even if it is a stromal edema, the intraocular pressure is not higher than normal. So it depends on the rigidity of the cornea itself.
Yes, so it is actually corneal edema causing increased thickness. Yes, as you say, reduces the pressure reading or gives us a false lower reading.
False lower.
Yes. So thank you very much, sir. Do we have any comments from Professor Ahmed Al-Masri, please?
Yes. Thank you, Dr. Ayman, for this very informative presentation. طبعا كالعادة يعني. I have some comments. طبعا I do agree 100% with the ORA. It was يعني فعلا بالنسبة لي كان حظي كويس إن I have the first ORA machine in Egypt. So again, I'm routinely doing ocular response analyzer for all my patients before LASIK surgery, just to have an idea about the pressure and the control as a basic line. And I even put this ORA sheet for him in his file to be kept with him all of the time. And then on the follow-up, I'm doing the regular ORA or take the difference. As you said, this is a very valuable tool, and maybe ORA is not only valuable for the cases of post-refractive, but in many other cases, like in children, like in difficult patients, like after cataract surgery. So it's a very beneficial tool for the pressure, as you said, and not like the Corvus, as you said, in the biomechanics. So I do agree with you with the concept of the ORA. But the second point of the PRK, I'm not giving steroids for 6 weeks. I'm just giving them for 10 days. Even with 10 days and the mitomycin C for all of the cases during surgery, the incidence of his is nearly nil. So I
don't use mitomycin C. That's the difference.
In the PRK, you don't use.
In the PRK, I don't use mitomycin C. That's the difference. So I have to be on steroids for longer time.
Why not?
I depend on the iced saline. I depend on the iced saline. I give a lot of iced saline after ablation, and I wait with the iced saline for some time. But I don't feel that that I need to add mitomycin C. I don't have any instance of his, and I don't like putting material on the cornea that may make the epithelial healing slower than normal. In an individual who is not a patient.
Different schools طبعا يعني I do respect your school. Okay, the third point is about the optic nerve compromised with the microkeratoma during LASIK surgery. There are many papers that have been published in comparison of doing OCT optic nerve before and after refractive surgery, whether the PRK or LASIK. And at the end of the day, they didn't find any difference on the effect of the optic nerve. But now we are in a way to do a new study, doctorate degree, comparing the OCT findings before and after PRK, LASIK, and the femtosmile. As also the smile, we don't induce too much pressure. It's like the femtoflap, just 24 millimeter mercury, yes, for a longer period of time. And this may be a very important point, especially in high myopes. Maybe for the regular patients, yes, I do agree. Maybe there is no difference in the OCT findings on the optic nerve after the surgery. But in high myopes, I feel it is very compromised for the optic nerve. And I do prefer doing the femtosmile for the high myopes, as they are not candidates for PRK, to avoid raising the pressure during the surgery in LASIK procedure. But what's your opinion in this point for high myopes?
The point is that as you said, the studies didn't find a difference, but the studies were done on normal people not affected by glaucoma. Yes. The problem of glaucomatous people that they have a higher rate of nerve fiber loss per year, more than usual. So you may accelerate this rate. That's the point. This needs follow up for a long time and needs a patient with already compromised optic nerve, and it's difficult to find a good number for that indicated for refractive surgery.
This is the point that I want to ask you. A patient with glaucoma, usually I consider it as an absolute contraindication for doing LASIK. I don't know. I know that you don't agree with me because you said that you can do patient with glaucoma compliant on one drug to do refractive surgery. مش عارف رأي حضرتك ايه في حته
I used to be much more conservative than you, but I don't know why not in this.
Yes, a big debate whether to do or not refractive surgery for patient with glaucoma.
It's glaucoma is well known.
They are young people asking
yes,
for
yes. This is the point, young people. So let us try to find a point of intersection. We consider glaucoma as a relative contraindication for refractive surgery.
Okay, thank you, Dr. Ayman.
You're welcome.
This is very interesting because the one who is agreeing to do the laser vision correction is a glaucoma man or a glaucoma specialist, and the one who is very cautious, he is the one who is a master of refractive surgery. So just to come in the way in between, and I think if we have a very safe, and I actually manage a lot of juvenile glaucoma cases, but I know them for long years, and I find their field stable, and I find their IOP in the lower teens, and they eventually come after years of follow-up of glaucoma. They, in their early 20s, they come to me, please do us refractive surgery. And actually, I agree with Ayman, I will happily do, because I know these patients for a very long time. But I will go to Professor El-Masri side if I have a glaucoma patient whom I don't know. I need to know the glaucoma patient for a very long time before taking decisions in his actually comorbid situations. Long time, I mean years. So actually both sides of the argument are very correct, I think.
I agree.
شكرا جزيلا.
Thank you very much.
Thank you, Dr.
Thank you. And now actually we move to the last and again not the least part of the of this interesting episode of glaucomatology, And we have heard from the experts about the comorbid situations with laser vision correction glaucoma and cataract endoglaucoma. But now we steal some part out of the cataract surgery. What about the usual cataract surgery, the normal cataract surgery, which we all do, and maybe because we know that our patient is not a glaucomatous patient and we do him cataract surgery and we sleep very well, deep asleep and happy and content that there is nothing wrong with his intraocular pressure or glaucoma related. So we'd like to hear about this from our dear Professor Dr. Nader Bayoumi and his experience in this.
Thank you very much, dear sir. Good evening, everybody. At first, I would like to express my deep honor to be a co-speaker with my very eminent professors, Professor Al-Masri and Professor Asheti. Thank you very much for this marvelous opportunity, and thank you very, very much, dear professors, for sharing with us your vast experience in these two very interesting topics. Now, as for my talk today, this is a short telegram about an issue that is sometimes a source of concern, or I dare not say panic, among the routine cataract or phaco surgeon, who sometimes finds the issue of intraocular pressure a rather gray zone or a rather source of panic or concern sometimes. So let's decipher some of the code of the intraocular pressure elevation after cataract surgery in a very short telegram. Now, if we look at the intraocular pressure elevation after cataract surgery, let's try to consider two issues. Let's try to consider the timing of the cataract surgery and the details of the cataract surgery, whether it was eventful or uneventful. So let's start considering first if the intraocular pressure elevation occurs early, and by early we mean in the first 3 to 4 weeks after the cataract surgery, day 1 to day 30, in an uneventful routine cataract surgery phacoemulsification. What are the probabilities or the differential diagnosis or the possible causes? Let's say the number one, the most common cause, evidence-based and in all the studies, is retained viscoelastic material. Don't overlook this OVD that is left behind in the anterior chamber at the end of routine, uneventful cataract surgery as a very common cause for intraocular pressure elevation after cataract surgery. The second is a simple postoperative inflammation. Cataract surgery, again, is a planned ocular trauma that may result in significant postoperative inflammation, and the inflammation in itself is a source of elevation of the intraocular pressure. And the last issue about an early intraocular pressure elevation after an uneventful cataract surgery is pre-existing glaucoma. Don't forget that glaucoma patients are more prone to post-phaco IOP spikes. Not to mention, of course, whether the pre-existing glaucoma was under control or not, and whether the operating surgeon should have measured the intraocular pressure before the cataract surgery. Even if this is done, don't forget, please, that glaucoma patients are already vulnerable to post-phaco IOP spikes. Now, if the intraocular pressure elevation occurs after cataract surgery in the early period and the surgery was eventful, by eventful we mean something wrong has gone or has happened during the surgery. Whether this might be a residual lens matter in the anterior chamber or a rupture of the posterior capsule. When we deal with the rupture of the posterior capsule, there may be just the rupture with no dropped lens matter, or they may be just drop of a cortex, for example, in the very final stages of phacoemulsification, or maybe in the early stages and we were lucky enough to be able to remove all the nuclear fragments, but only the cortex fell. Or the most drastic nightmare of phaco surgery is the dropped lens nuclear fragments, of course, in cases of rupture posterior lens capsule. Or the whole bag is intact, we managed to preserve it, but there was extensive iris manipulation or trauma. So these might be the causes of elevation of the intraocular pressure in the early period after cataract surgery, the first, let's say, 3 to 4 weeks. Whether the surgery was uneventful, please don't forget retained viscoelastic. Whether the surgery was eventful, please don't forget rupture posterior capsule with drop of lens material into the vitreous. What happens if the intraocular pressure elevation occurs late? By late, we mean after the first month. Again, we'll consider whether the cataract surgery was uneventful or eventful. If the cataract surgery was uneventful, there may be that there is an inadequate control of the postoperative inflammation. If the post-operative steroids were not given adequately, steroids or non-steroidal anti-inflammatory, whatever anti-inflammatory treatment that the routine phacosurgeon prescribes to the patient, if this was not adequately prescribed or not adequately used by the patient, inadequate control of the intraocular pressure might result in a pressure elevation that would appear late. Or let's take the other side of the spectrum. The patient or the phacosurgeon were overzealous in the treatment, and extensive steroid treatment by luck met the unfortunate steroid responsive patient, and steroid responsiveness might then be a cause for the elevation of the intraocular pressure, or there is an aggravation of a pre-existing condition. That's, for example, say neovascular glaucoma that has been aggravated by the phacosurgery. This is very well possible. If the intraocular pressure elevation occurs after the cataract surgery and the surgery was eventful, that is, there was a complication, then there may be a late presentation of an intraoperative complication. A late presentation of intraoperative complication, any of these complications that we've mentioned intraoperatively might present late enough with the elevation of the intraocular pressure. So, the diagnosis, of course, keeping in mind the history of the cataract surgery, the operative details of the cataract surgery, as we've just mentioned, are very important. The surgery was eventful or uneventful, and what happened exactly during the surgery. If the treating physician dealing with or discovering the elevated intraocular pressure is not the phacosurgeon, then good operative records, or at least a note from the referring physician, is mandatory to be able to manage the case. The diagnosis after the history and the involving the examination involves, of course, the examination of the anterior segment or the posterior segment. Key issues to look at include the cornea, the anterior chamber, and the iris, and for the posterior segment, of course, fundus examination. For the cornea, please don't forget that if the cataract surgery involved a lot of manipulations and was a little bit traumatic, pardon me, the cataract surgery involved a lot of manipulations or was a little bit traumatic, then corneal edema might be faced with post-operatively. And please don't forget that this is a pitfall in the measurement of the intraocular pressure. As Professor Shetty has just demonstrated, the fluid present in the interface between the flap and the cornea. This is another source of error in measurement of the intraocular pressure, corneal edema. Then, looking at the anterior chamber is expected to be deep after a routine phaco or a cataract surgery, but be warrant of the cells or the lens matter, whether cortex or nuclear fragments, be warrant of flare, or even if the surgery was very, let's say, very traumatic, you might even find hyphema or blood in the anterior chamber admixed with the inflammatory cells or whatever residual lens material or OVD present in the anterior chamber. Moving to the iris, of course, if the surgery was traumatic and involved a lot of manipulations, you might find a frank injury to the iris or just simply a muddy iris reflecting excessive manipulations. Mentioning the fundus and the posterior segment, the findings might include vitritis, for example, the presence of cells, or simply vitreous turbidity if the cells are not quite visible. The lens matter, especially using the indirect ophthalmoscope, may be quite visible with the fundus examination, whether nuclear fragments or cortical material. So these are points to note in the examination of the eye after cataract surgery, in which case an intraocular pressure elevation is faced with. Now, what about the treatment of such a condition? The usual paradigm for all the treatment in medicine, not just in ophthalmology, is treatment of the cause if this is amenable to treatment. And the second is the treatment of the manifestations, in which case we speak of an elevated intraocular pressure. So for the treatment of the cause, if we're dealing with an inflammation, then the treatment would be anti-inflammatory treatment. So let's not panic to give or prescribe steroids in a case of elevated intraocular pressure if we diagnose the cause of elevation of the intraocular pressure as a residual inflammation that is not adequately treated. It's not the issue here of a steroid responsiveness, it is the issue of an inflammation that is not adequately treated, and hence here the correct treatment is to provide even more and more steroids in such a case. If the diagnosis is proven to be a retained something, whether an OVD or a lens matter, then treatment of the cause would involve removal of this retained material, whether the OVD or the lens matter, if it is not going to be, if the clinical course does not demonstrate that it is going to be cleared by the usual circulation of the aqueous humor. Of the elevation of the intraocular pressure, were the notes that are worthy to mention are simply, of course, elevation of the intraocular pressure is treated either medically or surgically. For the medical treatment, let's not forget that aqueous suppressants generally, they have the very good advantage of being very effective in lowering the intraocular pressure, but in this situation, they lower the intraocular pressure with the disadvantage of delaying aqueous humor turnover and hence clearance of the particles. This argument has to be very well considered when prescribing aqueous suppressants in a case of elevation in intraocular pressure after a cataract surgery. Prostaglandins may be the routine or the first-line agents in cases of chronic primary glaucomas, but please let's not forget that they increase the inflammation because they are actually mediators of inflammation, and we're already dealing with the post-cataract surgery eye. Myotics, of course, are contraindicated as they are in any inflammatory glaucoma. Surgical treatment, we're going to deal with the situation as any chronic glaucoma if the condition becomes chronic for whatever reason. So, to detail, or tailor these flow charts on the situations. If you're speaking about an intraocular pressure elevation, which is early within the first 3 to 4 weeks in a cataract surgery that was uneventful, we consider the cause. The most common cause at first is a retained viscoelastic material. For the treatment paradigm, we consider first wait and see on no treatment. If the intraocular pressure elevation is not marked, if the optic nerve is healthy, it is not compromised, the patient is not a non-glaucoma patient, the patient is still has a relatively healthy eye and all over, then we can simply wait and see on no treatment for a short time to see whether the condition is improving spontaneously or not. If you're going to prescribe IOP lowering therapy, let's not remember again and again, aqueous suppressants, they delay the clearing of the viscoelastic and avoid, of course, prostaglandins and myotics. And the final option, if the condition is non-resolving, don't forget that the option of doing an AC wash to surgically remove, the retained OVD, is still a valid option that would cure the condition if it is not self-limiting and not responding to the topical IOP lowering therapy. For post-operative inflammation, please don't forget the issue of using proper anti-inflammatory treatment, be that steroids or non-steroids. And again, while we are considering intraocular pressure lowering therapy, please remember that aqueous suppressants, they delay clearing of the inflammatory debris from the anterior chamber. Prostaglandins and myotics, they increase the inflammation, so they're not to be used in such a situation. And for pre-existing glaucoma, if the patient may have got mixed up with the post-operative, the post-operative treatment prescribed by the surgeon for the surgery, the patient may sometimes skip using their routine IOP lowering therapy. So just revise with the patient, or maybe reinstitute or perhaps increase whatever the regular glaucoma treatment. We might actually need to increase the glaucoma treatment, having mentioned that glaucoma patients are already more liable to a post-operative intraocular pressure spike after routine cataract surgery, even if it was uneventful. For the residual lens matter, what if the cataract surgery was eventful? As we're seeing here, there is a residual lens matter in the anterior chamber. Well, sometimes if it's a small cortical piece or fragment, the anti-inflammatory treatment may suffice, and the macrophages might eat up this small part together with a push with some sort of medical IOP lowering therapy again and again for the third time. Please don't forget the problem with aqueous suppressants, prostaglandins, and myotics. If this condition is not clearing, then we have to consider, of course, re-intervention to clear these residual lens matter in the anterior chamber. Sometimes the issue is clogging of the trabecular meshwork by the lens matter. Sometimes, again, waiting and seeing and no treatment, that is a conservative policy, sometimes work, but don't push your luck. Of course, if you're seeing that it's not working, the pressure is persistently elevated, of course, we will not wait for the optic nerve to be compromised. But let's say if it is already compromised, if all these odds exist, then please save the patient an unnecessary and an undue and potentially harmful delay, and just go in and to perform an AC wash to remove these residual lens matter remaining in the anterior chamber. And then we come to the I believe that the nightmare maybe of phaco surgery with interrupted posterior lens capsule. Sometimes without any dropped lens matter, the vitritis in itself from disruption of the anterior vitreous space and vitreous prolapse, sometimes this in itself incites vitritis enough, severe enough to elevate the intraocular pressure, for which situation we can employ the policy of wait and see, in which case treatment might involve systemic steroids, which provides maybe higher doses to the posterior segment of the eye, although topical steroids in the presence of in the absence of, of an anatomical barrier between the anterior and posterior segments of the eye would allow a sufficient dose of anti-inflammatory treatment to reach the posterior segment, yet systemic steroids are still preferable in such a situation. And again, our routine IOP lowering therapy with the same precautions. If there is a dropped lens cortex, the attention here has to be heightened for the same regimen. And if there is, of course, a dropped lens nuclear fragment, attention has to be heightened. And I believe vitrectomy, postplano vitrectomy with removal, a regular routine postplano vitrectomy by a posterior segment surgeon, not just the anterior vitrectomy that could be performed by the routine anterior segment surgeon. I'm speaking of a regular routine postplano vitrectomy by an experienced posterior segment surgeon to remove all the lens matter that has dropped, be it cortex, be it nucleus, more so if it is a nuclear fragment. Of course, this is very, very important to manage the lowering of the intraocular pressure. In such case, again, vitrectomy is an IOP lowering surgery in such a situation, because this, as such, it is identifying the cause of the problem. For iris manipulation or trauma, again, this is an issue of inflammation, in which case we need extensive anti-inflammatory treatment, again, be it steroids being non-steroidal, together with the IOP lowering therapy with the same precautions. And if it is a late elevation in an uneventful cataract surgery, then let's say if it was uneventful, then the most common cause would be inadequate control of postoperative inflammation, in which again and again and again we stress the importance of adequate anti-inflammatory treatment, whether steroids or non-steroidal anti-inflammatory treatment to decrease or to control the inflammation, because sometimes patients inadvertently they stop the steroid treatment or the anti-inflammatory treatment very early. We see patients sometimes stop it after 1 or 2 weeks, in which case the inflammation is still not yet under control. Let's take the other end of the spectrum. If the patient proves to be a steroid responsive, we would distinguish from an inadequate inflammation, of course, by finding a very quiet or a relatively quiet anterior segment of the eye. There are no signs of inflammation, yet the patient, on questioning and by the history, is still using an extensive dose, most probably of a potent steroid, for a long time. Maybe this might raise the possibility, or maybe if there are no signs of inflammation at all and the patient is a steroid responsive, then this patient is by definition, this patient by definition develops an elevation of the intraocular pressure with relatively shorter doses of less potent steroids for shorter periods of time. Then the clue would be absence of inflammation in the anterior segment of the eye, in which case you might be courageous enough to decrease or stop altogether the steroids, or maybe shift to a non-steroidal anti-inflammatory therapy, sparing the patient the risks of steroids. And another condition worth mentioning is an aggravation of a pre-existing condition, such as, for example, neovascular glaucoma. In a lot of situations, we find even after an uneventful cataract surgery, neovascular glaucoma progressing even faster and faster. And so we manage as the routine management of that specific condition, irrespective of the cataract surgery. If the surgery was, the cataract surgery was eventful and there is a late elevation of the intraocular pressure, then management algorithm is the same as the management for early elevation of the intraocular pressure. Sometimes we see, especially the complication of dropped lens fragments in the posterior segment, sometimes the elevation of the intraocular pressure presents late, sometimes, in which case the treatment is the same. We just need to perform a routine vitrectomy to remove any dropped lens fragments. So, as a wrap-up of this issue, we should not It should not provoke significant concern or panic to the managing physician. Just know the details of the cataract surgery, keep an accurate operative record, please, or contact the referring phacosurgeon if the record is not available. And always consider that intraocular pressure elevation has diverse etiologies, not just one etiology, with diverse specific treatment approaches. Remember, as a reminder, OVDs, inflammation, and pre-existing or pre-morbid or pre-operative glaucoma. Thank you very much for your attention. Thank you very much. Done.
Thank you very much, dear Dr. Nader Bey, for this very interesting talk, actually, about things we all meet in our practice. And I'd like to take you back to the beginning of your presentation and have some questions I think many of the audience would like to hear from you.
Sure, sir.
First, personally, how often do you measure the intraocular pressure after your routine cataract surgery? And if you have a recommendation for us surgeons in this regard.
Okay. Well, there are two issues. The issue is, by the book, we can measure the intraocular pressure immediately after cataract surgery. There's no contraindication, there's no scientific medical contraindication for that. But we all know that we are all afraid post-operatively from the issue of infection. So if there is no absolute indication to measure the intraocular pressure, in other words, if the surgery is uneventful, the eye looks quiet, the patient is not a glaucoma patient or a controlled, or is a glaucoma patient but a controlled glaucoma patient, the optic nerve looks healthy, all these issues mean that there is no absolute indication to measure the intraocular pressure early. So let's say not before 3 to 4 weeks do I measure the intraocular pressure to make sure things are okay. If the surgery was eventful, if the inflammation appears so severe, if there is any medical condition that is obvious in the post-operative examination that would raise the suspicion of an elevation of the intraocular pressure, I think I would measure the intraocular pressure as early as 2nd or 3rd day post-operatively. I think so, but taking all precautions to avoid infection, of course, this is the nightmare.
And then you talked about the role of OVDs in elevating the intraocular pressure.
Definitely, yes.
So how careful are you to remove how much percent of the OVD out of the eye following surgery? And if you think there is a difference between various OVDs in this regard?
Yes, sir. The issue of different OVDs, let's start with it. Yes, definitely methylcellulose produces a higher elevation of the intraocular pressure than sodium hyaluronate. It is more apt to remain in the eye post-operatively. Of course, I dare not comment on cataract surgery in the presence of Professors Al-Masri and Professor Sheti. I'm not talking about cataract.
We'd like to hear also from them, actually, a short while, but yes.
Let's say I would dare say I faced actually one issue with Professor Al-Masri specifically. You may remember the case, which is an issue of capsular block syndrome. Sometimes in many situations, actually the case was referred to Professor Al-Masri from some other colleague. The OVD was removed very carefully from the anterior segment, from the anterior chamber, anterior to the IOL. And the surgeon apparently missed a big bolus of viscoelastic posterior to the intraocular lens. Post-operatively, for some reason, the surgeon was not lucky enough to have a capsular block syndrome, and the OVD escaped to the anterior segment with significant elevation of the intraocular pressure. So I'll just stress these two issues. The issue is the type of viscoelastic. If you're using something other than methylcellulose, sodium hyaluronate, chondroitin sulfate, whatever, these types of OVDs that are easily removed from the eye. And just let's not forget removing that part that is present in the capsular bag, because this is a significant source of, let's say, a sequestered OVD that sometimes passes to the anterior segment post-operatively. That's
you have a certain technique, Dr. Nader, for removing the OVDs from behind the intraocular lens?
No, I dare not say that again, but I would just say rocking the intraocular lens by the, if I'm using a bimanual irrigation aspiration of the routine phaco machine, just rocking the intraocular lens by the irrigation port or by whichever instrument, just rocking it sideways would be enough, I guess, to displace, rocking it sideways while allowing the current of the fluid to pass all around. It would move most of the viscoelastic out of the bag. I believe so.
Okay. Dr. Ahmed and Dr. Ayman, please stay tuned to answer this. And also, now my last question for you, Dr. Nader.
Sure,
again, you mentioned about residual cortex in the anterior chamber, and you said that they are removed, or we have to remove them if they do not clear fast enough. How fast do you think is enough? How long do you wait before encroaching on removal of the cortical residues in the AC?
Again, sir, this is not evidence-based, of course. This is just an anecdote. The main issue is not to set a definite number, but the main issue is the clinical course. I would follow the patient every second or third day. If the follow-up in the clinical course proves that the condition is improving, then whatever the duration is not an issue. But if the amount of cortical matter is decreasing in peace, decreasing in size in peace, if the examination proves that this cortical matter or whatever lens matter is not clearing in peace, then intervention is mandatory. I would not give more than 1 to 2 weeks, and even 1 to 2 weeks is a long period. I would dare say, let's say from the end of the first week, if the clinical course does not prove it to be clearing, I would be courageous enough to intervene again. I would say so.
So the shortest time to wait, the shortest interval to wait is 1 week, in your opinion?
I believe so, sir, because the cornea, the hit to the cornea and the ciliary and the ciliary pump, in order to avoid ciliary body shutdown or injury to the blood aqueous barrier. I mean, other issues. I mean, other not related to the intraocular pressure. The hit to the cornea and the hit to the blood aqueous barrier would be so severe if we intervene that early. So it's an intricate balance between not waiting too much and not harming the eye by re-intervention that early.
We'd like to hear the takes of Dr. Ahmed and Dr. Ayman. And
Dr. Ahmed is raising his hand.
اتفضل يا دكتور
So
أيمن.
please.
اتفضل حضرتك.
دكتور احمد raising his hand. اتفضل يا دكتور احمد.
لا اتفضل حضرتك.
يقول لنا
اتفضل يا بيه.
هو انا عندي بس كومنت على ال measurement of intraocular pressure after cataract surgery. When I do cataract surgery in a well-controlled glaucomatous patient, and he's well controlled on his medication, and the decision was to do just cataract surgery without glaucoma surgery, then I asked him to stop all glaucoma medications, and I measured the intraocular pressure starting from the second week, and I measured the intraocular pressure every 2 weeks. Usually the patient doesn't need to start his glaucoma treatment except after 2 or 3 months, and sometimes when when he was on a single eye drop, he may stop using the glaucoma treatment. But I start to measure it from the second week.
You are talking about a glaucomatous patient, Dr. Ayman.
A glaucomatous patient, yes, a glaucomatous patient, and asking him to stop his glaucoma treatment after cataract surgery.
Okay, sir. دكتور احمد اتفضل.
يعني نقطة الدكتور أيمن أنا ماشي بالعكس تماما. On the contrary, I don't stop the anti-glaucoma treatment because the patient will receive steroids after the surgery, which may increase again the pressure more. But after finishing the 25 days of the local steroid eye drops, I'm starting to remeasure the pressure regarding the glaucoma issue. And if the pressure is controlled, I stop here the anti-glaucoma surgery and to reassess if the patient will go back to his drops or not. I even measure the pressure every 2 weeks up to 2 months to be sure that the patient will not go back to his eye drops. I don't know whether my way of thinking is right or wrong. I don't have an evidence-based medicine for this point, but I believe for a glaucomatous patient, I don't like to stop the drops before the surgery, especially we are going to take steroids after the surgery for a long period of time. This is the point of a glaucoma patient who is controlled, and we are going to do cataract surgery for him. What's your opinion, Dr. Ahmed?
There is no single answer, Dr. Ahmed, for this, because there is the one who with advanced glaucoma who is having 3 or 4 medications, 3 medications, I mean, including the combined one. And there is another one who's having only 1 medication.
Yes,
actually, that one who is having only 1 medication might be the case. I agree with Dr. Ayman, and I can stop the treatment safely for him for some weeks. But I will not have the courage to stop a treatment, 3 medications for one patient who is on these medications.
Especially when the optic disc is compromised. As a matter of fact, the most important is how the optic disc is affected. Because if there is advanced glaucomatous optic neuropathy, then you need to keep him on low intraocular pressure. And actually, in these patients, it's very rarely to expose them to cataract surgery without glaucoma surgery. As a matter of fact,
I agree.
Usually, the patient, when I start with cataract surgery, and he is on glaucoma treatment. Usually, he has a good optic disc, and he's mostly on a single eye drops.
Yes.
Yes. So I would like to add, in my practice, if there is a glaucomatous patient who might not be cured by cataract surgery, and I mean he is he is on more than one medication or 2 medications, this patient I do not do cataract surgery alone. I usually go for combined surgery from the beginning, and I do my combined surgery because I have the closed system technique. I obey the closed system technique even in very advanced cases. But a cataract patient with advanced glaucoma, in my experience, is for combined surgery actually right away.
Yes.
Yes, I agree.
The point of further to Ayman.
I just agree.
Okay. Ask about the questions of Dr. Nader regarding the viscoelastics after the cataract surgery. Now, my routine in the straightforward cases without any zonular weakness or any problem in the pupil dilatation, I'm inserting my intraocular lens under saline, putting the irrigation solution from one side and inserting the IOL under saline, which is called the aqua insertion. This is my routine now for more than 5 to 6 years. The point is mainly it avoids the spike of increase of intraocular pressure after the surgery for 4 hours. And it's deadly sure that we don't have any OVDs left behind, especially for the trifocals and premium IOLs. The second point of removal of the OVDs, I prefer, if I'm going to put viscoelastic, whether methylcellulose or Relon, or in another terms, the cohesive and the dispersive OVDs, preferable the soft shell technique with the Archinov, or the Archinov technique, which is putting the visco cohesive in the bag and then the visco dispersive over the bag. This facilitates removal of the ease irrigation of the OVDs from the bag, especially for the premium IOLs, the trifocals especially, preferable to go behind the lens and to remove the OVDs. If you are not just tracking the IOL, but go with the irrigation and aspiration behind, or even with the irrigation only, because with the irrigation behind the IOL, it will push the OVD anteriorly. There is no need to go with the aspiration needle behind the IOL. Easier and safer to put the irrigation behind the IOL. It will push the OVD forward to the anterior chamber and to remove it. The third point of removal of the nuclear material from the anterior chamber. Honestly, after the surgery, if I find any lens matter in the anterior chamber, I don't wait. I immediately admit the patient to the OR. Don't wait for a week or anything. Just next day, I'm telling him that we have to go to the OR again, not for the glaucoma issue, but for the corneal endothelium. I saw cases of lost cornea or corneal decompensation from leaving some lens matter in the anterior chamber or part of the epinucleus.
You are talking about nuclear fragments, Dr. Ahmed, or some simple cortical material?
Even cortical material, I don't wait. Oh. Yes, even the cortical, I don't wait. I go immediately to the OR and remove it without hesitation. I don't even do 1 week. Okay. I'm against you in this point.
Oh, this is very, very interesting to hear. Yes. Okay.
And astonishingly, sometimes you find this lens matter a few years after the surgery. I found patient after 4 years, she came complaining of something in her eyes white. I examined her, it's not my surgery, luckily enough. And I found lens matter in the anterior chamber. I told her we have to go and to remove it. And this will not change the vision. Her vision was perfect.
Okay. So thank you very, very much for our very distinguished speakers. We were honored and pleased to have Dr. Ahmed Al-Masri, Dr. Ayman Sheti, Dr. Nader Bayoumi. I think it was a very rich session. And I think now we have to give way to the soccer fans, and probably Dr. Ahmed Al-Masri is on top of them, who would like to watch the match, which is starting probably in 45 minutes. So Dr. Ahmed, don't worry, you still have time. And actually, we promise you session 11, episode 11 of Glaucomatology would be another rich session, which will talk about the psychological management of our glaucoma patients and how to deal with the human being in the glaucoma patient, as well as future prospects of glaucoma management, surgical and medical. So thank you very much for staying with us and for our eminent speakers, and see you next week, God willing. Have a good evening.
Thank you so much, Dr. Ahmed, and thank you all for this very fruitful meeting.
Thank you very much. Thank you.
Thank you. Thank you. It's our pleasure. Thank you.
So if we thank you and see you next week.
Inshallah. Assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh.